Presentation is on physical therapy documentation requirements. It's based on CMS guidelines, APTA recommendations, and MRH requirements. The objectives of the presentation are to review chart review requirements, go over general best practices, and to review a few interesting CMS tidbits. For the chart review requirements, we'll go through each section of the chart and review what's necessary to include under each section. For the referral or order, the diagnosis on the order must match your CDER diagnosis, and the order must have the physician's signature with a time or date, which can also just be the received by timestamp. On your examination, you need to include your therapy diagnosis or diagnoses. You're going to want to include all conditions that may impact your treatment. The point of documentation is to establish medical necessity, so the more you include, the more justification for the need of treatment. You want to be sure that your diagnoses are supported by your subjective or objective information. If you have a therapy diagnosis of right elbow stiffness, then you should have right elbow range of motion measurements to justify that or to back that up. And your therapy diagnoses should be consistent with the referring diagnosis on your order. Under your history, the italicized pieces here are recommendations from CMS to help demonstrate medical necessity. The non-italicized pieces are things that the hospital requires that we include. You want to make sure that you address the patient's medical history. Again, we're trying to establish medical necessity, and if the patient has several comorbidities, that's going to help show a need for skilled intervention. You want to address their surgical history, including related and unrelated surgeries, again, just to give a general picture of the patient. You need to include the patient's chief complaint and the date of onset, and the hospital has that date of injury, so if it was an injury, then make sure you include that. You want to include the history of the current complaint so that we know when this happened, what the patient has done up until now, what the progression of symptoms has been. A pain level is recommended because it's another good way to establish medical necessity. It's not necessary. Some of your patients aren't going to have pain, and so that piece is not required, but it certainly is helpful to establish a need for treatment if the patient is having pain. You also want to include any treatments that the patient has had for this condition in the past year, and any medications they're taking. Again, medications can help establish a general medical picture of the patient, which can help establish medical necessity. You want to include their prior level of function, so what are you potentially trying to get back to, and how are they functioning now compared to how they were before this issue started. You want to include any recent hospitalizations, again, just helping to establish medical necessity. If they've been in the hospital, then there's likely a pretty good need for skilled care. You need to include the patient's rating of their general health, and again, this is all helping establish medical necessity, their current living situation, which can also help justify if they have stairs, then they need to be able to navigate those. If they live alone, they need to be safe being home alone. And then also asking about their fall history, which is an important thing to address with everybody because that's something that we can certainly help with intervention on decreasing patients' fall risk. Under the examination, you're also going to want to do the systems review. This is especially important for direct access, which hopefully we will have soon. You want to make sure that you can identify any red flags that you need to refer the patient out for. And in general, it's probably a good idea to at least get a blood pressure and heart rate on all patients just to make sure that they are in a place that they can tolerate treatment. You also need to include comorbidities. This isn't required, but it's certainly helpful to justify the need for skilled care. And it's also going to help justify any modifications if you need to extend your duration or if they're not making progress. Those comorbidities are going to help back up your treatment plan. You need to include objective measures to show any deficits that the patient has, and then also a functional outcome measure. And then the hospital does require that you address education. It's not required by CMS, but it's a good idea to have in there. For your evaluation, the goal is to establish medical necessity, which is the whole point of your documentation. And it's more than just checking the box that the treatment is medically necessary. You need to really demonstrate that. For your impairments, they should be supported by your subjective or objective documentation. Again, if you have right hip stiffness, then you should have some range of motion measurements to justify that. If you have left shoulder pain, then you should have said in there that the patient has stated they have left shoulder pain. You also want to include all the functional limitations, which should be related to those impairments. And then you need to include your clinical assessment or your impression. And again, this is your chance to justify medical necessity and the need for skilled care. You need to include your discharge plan and then a prognosis with a time frame. In your plan of care, you want to include any planned interventions that you're going to do. You also want to include your treatment duration and frequency. For the evaluation, this is going to be your certification time frame. It can be from 1 visit up to 90 days, but not more than 90 days. So if you're going to continue beyond 90 days, you'll just have to do a recertification. Your goals should be measurable, long-term goals, and they should be aligned with function. Your certification is going to be from the date of your evaluation through whatever your plan of care says, up to 90 days. And it should be signed and returned within 30 days of the evaluation. For your daily note, the following should be included if applicable. So your patient report, any adverse reaction to the treatment, any communication that you've had with other providers or family members. And in a progress report for your daily note on that day, you are going to want to include the patient report. That is required. The subjective report is required on the progress report. You need to include your interventions or modalities that you provided, the amount, duration, and you should demonstrate that skilled care was necessary. For instance, if you're having a patient do squats on the total gym, you want to say that they did 1 times 10 at whatever with cues for hip alignment, knee alignment. You're working on gait. You want to include that you had tactile or verbal cues, something that shows that skilled care was necessary. You want to include the total timed codes and the total treatment time, timed and timed, which in CEDAR-on is not, we have to put the time in for everything, so that is kind of included. You also want to put the patient's response to treatment. You don't just want to say that they tolerated the treatment well. You want to say, they made progress, they felt better after treatment, they struggled with something, they required cues with something, again, just to justify that it was necessary to have you there and to show that your treatment did something, hopefully. So for your plan, you want to include a specific plan for the next treatment session and not just say continue per plan of care. You want to include specific things that you want to address or things that you want to progress so that if somebody else sees your patient, that they can also continue your plan of care pretty easily. For your progress report or reevaluation, you need to include the date range of the reporting period. So that's going to be from the date of your evaluation until your first progress report, or from the date of the last progress report until your current progress report. And that's something that isn't necessarily automatically included in CEDAR-on. It's preferred that you include objective measures, again, an easy way to show progress. You want to have the patient redo the functional outcome measure to show that you're making some functional progress. And again, you want to establish medical necessity. That's your whole point of your progress report, is to show that you're making progress and that they still need skilled care. You need to include the patient's subjective report in the progress report. And then you want to update your clinical impression to show any improvements or explain any difficulties the patient is having or any lack of progress to justify a continued need. And then you need to include your plan for continued treatment. You also need to address your goals, and you always want to do that relative to function. Your goals should be linked to some sort of function. Your recertification is going to be based on the duration on your plan of care. So it needs to be at least every 90 days or 10 visits, whichever is shorter if it's a Medicare patient. Your evaluation counts as day 1 of your reporting period, so the 10th day that the patient comes in is going to be your recertification day. After you do a progress report, the following day is the start of the next certification period, the next reporting period. So you'll have the progress report will be your 10th visit, your 11th visit will start the next reporting period. You need to have your signed progress report, and it needs to have the date of the signature, or a received by date is fine too. As far as CMS goes, a new order counts as recertification. So if the patient goes to see their referring physician and they send a new order for 6 more weeks of treatment, that can count as your recertification. The hospital, however, does require us to have that signed progress report as our recertification. Under your discharge summary, a discharge summary is required for each episode of treatment, so you need to end the case with a discharge report. You need to include the date range of the reporting period, again, something that CDRON doesn't automatically include. So this is going to be from the date of your last progress report or from the evaluation if you haven't been seeing the patient long enough to do a progress report. You need to have the date of the episode conclusion, the reason for the episode conclusion, which again, CDRON helps. We have those boxes to check on that whether they met goals or there was a lack of progress or their insurance ran out. And then you need to address any changes in their status relative to their goals. So make sure you're addressing the goals and objective measures that you looked at to show that you've made progress. You need to have the patient, again, fill out the functional outcome measure to compare to your evaluation or your previous progress reports. You need to include the patient's subjective report, and then you need to update your clinical impression. And this, again, is your last chance to demonstrate that treatment was, in fact, medically necessary. So anything you can include in there to show that you were needed to help that patient is helpful if you get audited. You need to include your plan or recommendation for continued care, whether that's just to continue with a home exercise program or to follow up with the physician. And then you need to, again, address your goals. So just some extra stuff. Best practices, and this came mostly from APTA guidelines. So you want to limit your use of abbreviations. You want to include all related communications with the patient and others, including phone calls. So if a patient calls to cancel because they fell, that's going to be relevant and possibly justify more treatment. So you want to make sure you include any relevant information that might help justify medical necessity or affect the patient's progress. You want to focus on function, function, function. You really want to show what the functional deficits are and what progress in function that you're making. You want to document all comorbidities, complications, and relevant diagnoses, again, just to establish the general picture of the patient and to show the need for your intervention or to show why they might not be progressing as quickly as you would expect. In your daily note, you want to make sure that you're demonstrating the need for skilled care. So again, you don't just want to have a flow sheet of all the exercises you did. You need to include why were you needed for those exercises, any cues that you were providing or adjustments you made to the plan. You want to make sure that your daily notes are not just repetition. You don't want to just have the same thing on every note. You want to make sure that you're showing progress, that you're showing that you're necessary, that it's not just something that a family member or a personal trainer could do. In your interventions, you need to include the time, the frequency, and the duration of each intervention. You want to make sure that you have objective measures to back up your impairments and functional limitations. So if they have stiffness, you should have range of motion measurements. If there's weakness, you should have strength measurements. And then just some interesting stuff from CMS. You actually don't need recertification for every progress report. So again, if your initial certification is for 90 days and it's a Medicare patient, you're going to have to do a progress report at 10 visits, but technically your certification is still valid. So you still have another 30 days if you do the progress report at 60 days before you need recertification. To simplify things, it's easy just to require that we get the signed plan of care just to keep everything streamlined. A signed plan of care actually counts as a certification with or without an order. So if you do not have an order and you create your plan of care and send it to a physician signs it, that technically counts as your certification. Again, just logistically, way easier to make sure you have a referring physician who is going to follow up and sign those plans of care. And a new order, I talked about this before, a new order from a physician does count as recertification. So if the patient sees their physician in the middle of a certification period and they send a new order for 6 more weeks, then that technically counts as recertification for 6 more weeks of care if you needed that. And a delayed certification is actually allowed with an explanation. So if you do not have that signed plan of care back within 30 days, CMS recommends that you do not stop treating the patient as long as there is still a treating physician. And then when you do finally get that plan of care signed, there needs to be some explanation as to why it was delayed, if the physician was out of town or whatever the case may be. Again, to simplify things, the hospital just requires that we have that at that 30-day period before we can, so that we can continue seeing the patient. According to CMS, you can add treatment modalities to your plan of care as long as there hasn't been any significant change in the patient's status and there's no reevaluation necessary. If you just decided that, oh, now the patient's at a point that I want to use ultrasound, then you can add that treatment modality in the daily note and then just write in the daily note why you're adding that modality. You can actually do a second evaluation within the same episode for a completely new problem. So if the patient comes in with a whole new problem, you can do a new evaluation within that same episode, as long as you have an order from the original physician or the original physician is willing to sign the plan of care for the new problem. Again, easier if we just follow up with the physician and not assume that the current physician is willing to sign the plan of care for a problem that the patient hasn't seen them for. Pain level is not required, but it does help with justifying medical necessity. Some patients are in for problems that aren't related to pain, so it's not required that you have pain level, but it's definitely an easy way to justify that the patient needs some help and some skilled care, and also to show progress. And according to CMS, an evaluation is an untimed code and treatment can begin before your plan of care is written. So you can begin treatment on that first day. So you can bill for any treatment that you do perform on that evaluation day. Again, the hospital right now is saying that they don't want us to do that. And if you plan to taper your frequency, you're going to start with 3 times a week and then eventually work down to 1 time a week. You can just include your starting and ending frequency for that duration. You don't have to show exactly how you're going to taper it. And maintenance is actually acceptable if it's appropriate and justified. So you need to show that the patient does require skilled care to maintain or prevent deterioration of a condition, and that what you're doing is not something that a family member or an unskilled provider could perform as well. You want to make sure you document that skilled care is necessary in the daily notes. Again, you want to say if you provided verbal cues, tactile cues, if they required assistance for different activities or exercises, that they require monitoring for safety. All of that is going to help justify skilled need, even if it's just for maintenance. And last, your discharge is your last opportunity to justify medical necessity. So that is an important piece, making sure that you really do use that discharge summary to show that the patient did require skilled care and that they made progress and you were needed to make that progress. And that's the end. Thank you.